Over the last decade, adolescent screen engagement shifted from intentional browsing to passive consumption, driven by algorithmic curation. Platforms engineer specific features, like infinite scrolling and randomized rewards, to create deep, dopamine-driven habituation loops. In response, schools and public health organizations launched a wave of digital wellness programs to combat what was identified as a rising health crisis. We now have over a decade of empirical data, stretching from 2013 to 2024, to evaluate whether these awareness campaigns actually work. This transition from anecdotal fears to empirical measurement allows us to see exactly which of these programs are delivering behavioral results. Researchers utilized the PRISMA framework, a rigorous methodology for scoping reviews, to filter a massive trove of global research down to the most reliable empirical studies. This flow diagram illustrates that filtration process. Out of over 6,400 initial references, researchers whittled the data down to a core of 93 valid empirical articles. This dataset is immense. It represents 81 distinct interventions tested across approximately 75,000 adolescents globally. In 20% of these studies, researchers found absolutely zero statistically significant improvements in healthy screen use. One example is the Australian Health for Life trial. Despite reaching 6,640 students with high implementation adherence, the program failed to modify actual health behaviors. When massive, well-funded programs fail to change adolescent habits, we have to look deeper into how these interventions are actually built. To diagnose how these interventions attempt to alter habits, we apply Mishi's behavioral change wheel. This node map visualizes the Mishi framework. Mapping these studies reveals severe clustering. 78% rely entirely on education, and 34% utilize training. Look at the neglected external influences. Restriction and modeling sit at 1%, and coercion is 0. Our current public health strategy is architecturally lopsided. We rely on telling teenagers about risks rather than changing the environments where those risks occur. The ecological model of health promotion explains why this strategy stalls out. Knowledge transfer operates solely at the individual level. It forces the adolescent to exert constant, conscious willpower to succeed. On one side, you have a static block of acquired knowledge. On the other side, you have dynamic, algorithmic triggers, continuously overpowering that knowledge to form dopamine loops. Awareness of a risk cannot override an environment frictionlessly designed to exploit human psychology. Deploying school curriculums to fight algorithmic engineering is a behavioral mismatch. We are bringing a lesson plan to a structural fight. However, a select few interventions in the scoping review successfully reoriented adolescents away from excessive screen use and sustained those results. Programs like the Atlas Obesity Prevention Trial and the Take the Challenge program achieved measurable success. The core difference is their architecture. They stacked a foundational education layer and locked it into place with heavy, structural environmental restructuring. In practice, this means physically altering school recreation spaces, providing alternative equipment, and enforcing strict screen-free zones. Behavior change becomes sticky when interventions address an individual's personal agency while simultaneously modifying their external physical constraints. Effective digital wellness depends on a multi-level environmental stack that reinforces individual agency with external structural support. The scoping review also uncovered structural blind spots in the broader scientific literature. This global heat map shows the geographic myopia of the data. 80% of interventions occurred in high-income countries. The United States and Australia dominate this space, representing 25 and 19%. In contrast, there is a total absence of data from the African continent. This creates a cultural danger. We are copy-pasting individualist intervention strategies onto screen behaviors that manifest very differently in collectivist societies. Then there is the setting bias. 78% of all interventions are strictly school-based. Out of 93 studies, only 3 targeted the parent-adolescent dyad. This leaves parents entirely unequipped to enforce environmental restructuring at home. Our current understanding of digital wellness is trapped in a demographic and institutional echo chamber that effectively ignores the home environment. The final major blind spot is the total absence of equity-focused design in these interventions. Structural social determinants, like a neighborhood's lack of safe outdoor green spaces, directly drive up recreational screen time. Yet interventions rarely account for these economic realities. This matrix outlines the final research and policy blueprint required to fix these systemic failures. The next generation of interventions must move past education to deploy multi-level environmental restructuring, integrate the home environment, and explicitly design for demographic equity. To resolve the digital behavioral crisis, we must stop asking adolescents to outthink their screens and start redesigning the environments in which they live.